about improving access to cancer screening for people with learning disability. So if we could go to the next slide, please, Catherine, thank you. I can't see that slide at the moment, but essentially I wanted to introduce everybody and also talk a little bit about the Cancer Alliance. So for those of you who are not sure, the Cancer Alliance stretches across north central London, and we're a NHS organisation. We're part of 21 alliances across England and cover all the boroughs in north central London. Our raison d'etre is essentially to improve the outcomes for people with treatment for cancer, improve our championing of cancer across the whole of the pathway, from screening and early diagnosis through to treatment and care beyond. We're keen always to incorporate research where we can into our work, and our partners include all of you, our patients, our hospital trusts, our GP practices, our healthcare commissioners, our local councils and our charities. So thanks for joining us today. I'd like to introduce to you part of the team that you know already. You've met many times before, both Catherine, Nesta and Fanta. Perhaps you might want to wave, both of you. There we are. Thanks, Fanta. And
Hello.
Today, particularly, we've got Carole Dukes from, and you've brought Amrah with you from Barnet Mencap. We've got Deborah Snook from Islington GP Federation. I can see there. I've got a few people on my screen that I can see. You've got some other federations. Amina from Barnet and Lorraine Wells. I can't see anybody else, so I will think what we should need to do is move into the business of the day. Thank you again for joining us, and I'd like to hand over to Carole, who's going to take us forward. Thanks so very much, Carole, for coming today and for leading the presentation.
Thank you very much, Claire. It's our pleasure to be here today. This is a project we started just over a year ago with Healthwatch Barnet and Public Health. And it was decided to do this work based on the figures we'd seen on cancer screening and the fact that it was particularly low amongst people with learning disabilities compared with the rest of the eligible population. We wanted to find out why this was. We wanted to know what were the barriers to people with a learning disability and what could we do to actually remove those barriers, and why we weren't getting across to the service users or to their parents and carers the importance of screening, particularly as many of them live at home or they live in supported living circumstances. So with this in mind, we made a film, and the film was commissioned by the Public Health team, funded by the Cancer Alliance, and features people with a learning disability and professionals. And it was made to promote screening to multiple audiences, people with learning disabilities, their parents, carers, and healthcare practitioners and social care providers. In its entirety, the film is 20 minutes long, and it focuses on those cancers that are covered by the national screening programme, so i.e. breast, bowel and cervical cancer. And we've also made 3 shorter versions of the film, one for each of the cancer screening programmes. So all these films, plus a lot of downloadable, easy read information, will be available for you to use and share as you wish. However, for our purposes today, we're just going to show you 4 extracts from the 20-minute film, the ones that are most relevant, with the opportunity to have a short discussion between each one. And finally, one extra point I need to make is that since we made this film, the age of bowel cancer screening has widened to 56, not now 60 as it says in the film, and it's likely to widen further in the months to come. So the first extract features people with learning disability talking about their thoughts about cancer. Thank you, Amrah.
Thanks, Carole. So I'm just going to share my screen with you. Can everyone see the screen?
Absolutely. Thanks, Amrah.
Thanks. I'm just going to start playing the video.
So if you were to receive a letter that said to come in for a cancer screening, how would that make you feel?
No, I don't know. Have to process all of that.
I won't feel so nervous now because I've already had one.
I feel scared because in case I find out that I had got cancer.
Upsetting.
Scared, nervous.
Just go and see what will happen. You don't know what will happen unless you actually do it.
Cancer screening is an important part of cancer prevention. If we can catch cancer early, then it means that treatment is more likely to work and more people survive.
People with learning disabilities are not as likely to be screened, so we need you to work with us to improve these numbers. Uptake of preventive services such as screening is low among people with learning disabilities.
There's all different types of cancer around the body.
Cancer is a illness or disease that can affect any race or nationality or any age or gender.
I think cancer is like a disease.
Cancer is a reverse engineering of somebody's biological beings. So instead of us growing positive things, it absorbs those positive things and creates like a black hole inside a human being. And then that spreads and grows and grows. So it's like a vacuum.
Disease that could kill you.
What people have and cancer kills you.
You hear cancer. I know many people that have died of cancer. My mother passed away with cancer. It was so quick. So it's, to me, it's a really scary. You hear the word cancer and you think, oh my goodness, it's like doom.
Cancer has to do with our cells. Cells are small units that make up living things, including our bodies. Our cells grow and divide, and when they don't do this normally, they turn into cancer.
Well, biblically we'll say bosoms.
Boobs, breasts if I'm in a GP.
Okay then, melons.
Bosom.
Boobs.
Breasts, boobs, boobies.
Tits.
Just boobs and tits.
Vagina.
Vaginal room.
Vagina.
Oh, there was a friend who used to call it nunny.
Bottom, bum, arse.
Posterior.
Well, in Yiddish we call it tuchus.
Butt.
Arse. Oh.
No matter what you call them, they can all be affected by cancer. We're going to talk about 3 different types of cancer: breast, bowel, and cervix.
Thanks for watching. That was the first part of the film.
Thanks, Amrah. So we're going to go over to Claire now to have a discussion about language.
Thank you. So one of the things that film really clearly illustrates is the range of different words, constructions and language that people use to describe cancer, and particularly within the learning difficulties community. You'll see that people use sometimes language of that maybe is probably easier to understand to most people, is more accessible, and it's important that when we talk to patients with learning difficulties that we ensure that our language mirrors that and matches that. There's a huge range, as in people without learning difficulties, there's a huge range of what people feel comfortable with language, and I think the film really adequately illustrates that. Carole, did you want to give some examples of what you feel, perhaps if we're talking general practice, where we sometimes don't explain things in a way that's easily acceptable or easily understood, and how we might do it better?
Okay, I think it's about keeping language very, very simple, because it often takes people with learning disabilities and autistic people longer to process what you're talking to them about anyway. So the simpler you can keep the language, talking slowly and calmly is obviously going to help them understand what you're saying. The other thing also perhaps to remember is to check their level of understanding, because particularly with autistic people, the way they understand and process information is very different to the rest of the population who aren't autistic. So a good way is to just ask them simple questions to check that their interpretation of what you've told them is the same. And I think those are the two most important things to remember. The other thing is perhaps if you've got any visual information you can show them, any way you can represent what's going to happen or what you're trying to explain using visual things to show them, that can also be a huge help. And if you have something called accessible information, which is just really easy read information, it's a template to make things easier to understand, and it just really involves clip art down the left hand side and simple sentences down the right hand side. But there's a lot of this sort of information and easy read available on our website to help you.
Yeah, and I guess I'm just going to draw out particularly one of the things that Carole has said that I think as doctors we don't always do, doctors and primary care staff, and it's always worth doing it whether we're speaking with patients who have learning difficulties or not, and that's checking back to understand someone's own understanding of what you've said to them. So it's worth saying, you know, can you explain to me what you think you've understood by what I've said, or how would you explain what I've said to somebody else? It's really important to do that, and actually wherever we come from, whatever walk of life we have, it's a really useful thing to do, and particularly important with this group of patients, I think. I don't know whether so this webinar, we want this to be a conversation really. So in terms of, we've got lots and lots of GPs on the call and primary care staff. I wonder whether any of you want to share any of your experiences or tips about communication that you've come across. In terms of the federations, we've got several people from federations here. Do you have something that you share with the doctors that work with the federation in relation to communicating with people with learning difficulties?
I'm from Barnet Federation. I'm one of the care hello there. I'm care coordinators. We've come on because we're about to start working with LD patients. So this is to help us. So we've not actually done it yet.
Right. Okay. Okay.
It's all right. I just don't want to silence.
Thank you. Absolutely. Thanks, Deborah.
Yeah, I think I'm also here as in representing my practice rather than the federation. Although I can relay what goes ahead. I think there are resources out there, but sometimes it's also quite hard to choose what you're going to do. Yeah. And I think for admin, I'm a practice manager, clinical performance manager, and picking the right thing to choose for the right person, I think sometimes is difficult for the non-clinician. I think it's difficult once you've got somebody in the room with you. It's a lot easier to target, but when you're recalling someone and everything else and phoning them up and then sending a follow-up letter, choosing the right resource can sometimes be a bit tricky, I think.
Of course, one of the things with federations is that an awful lot of your appointments are virtual, and a fair amount of appointments in general practice are virtual now. So we used to have, and across NCL in the past, when we were CCGs and also PCTs, we had some really good hard copy, easy read documentation, which we would share with an emphasis on health, which we gave to GPs, and they used to use those in their consultations. We haven't used those for a bit, and of course we've moved to a virtual environment to a proportion of our consultations. I wonder whether anybody thinks there would be mileage in producing summary sheets which could be emailed on Accurix or equivalent if you're doing a virtual consultation, or delivered via the SMS system that Accurix depends on. I'd be interested to hear what the GPs feel. I see Deborah nodding away, but and Carole, I don't know whether you've had any experience of putting together short bits of information that could be sent electronically almost during a consultation. which is something that this platform called Accurix is able to do.
Yes, no, I don't personally do that. We do have people in the office who will help with easy read accessible information. So if you needed some additional help, I'm sure that we could help in that respect. But I think the first step is to have a look at the Barnet Mencap website, have a look at the easy read downloadable information that's there, and then we can add and adapt to that as the appeal or demand requires, I think.
Thank you.
Yeah, just to add to that, James actually sent me a template for an easy read document today. So for this cancer awareness project, I'll be doing an easy read document to go with it. But he just sent it to me today, so I should have that out by today/tomorrow latest.
Okay, and then we could have a look at the length of it and see if it would also be the sort of document that can be apportioned into small sub-subject types to be emailed on via a text messaging system, which is what I was talking about before. So maybe chunking it up into smaller chunks might be helpful for people who are in the middle of virtual consultations.
Yeah.
Don't know whether anybody else. I'm having a look at who's joined us today on the chat. Oh, Deborah, you popped your hand up again, and I might come to Nitika. Deborah, what did you say?
So I was just wondering about branding, because I don't know how, because it's got Barnet and things written on. I'm wondering whether our patients being in Islington, whether that might be confusing for them, or whether I don't know. I'm not sure what their perspective will be, and whether we can have a broader branding that might not just put them off.
Yeah, no, I think that's right. We'll probably, I mean, Carole, what do you think about aiming for things which have an NCL geography to them? Be probably helpful.
Mm-hmm.
Yeah, that's great. Okay. Tara, you've popped something in the. Do you want to talk do you want to speak your comment?
Sorry, it's not Tara. I'm logged in. It's Serena.
Yes, it's Serena. I wondered about that.
Under my daughter's room. Sorry, I'm actually a doctor, and I'm half in this and half. No, I was just going to say that we have shared the easy read leaflets with all of the Barnet GPs, just as part of the sort of cancer desk as well. So it's huge initiative there, and just saying that I haven't actually tried sending it on Accurix, but it's definitely part of the annual learning disability sort of checks that we do with our nurses. We're kind of trying to push it that way, and also sending it to, we've got several homes where the patients tend to be, where there's sort of, quite sort of large numbers in pockets, and we're sort of making sure that the carers there have the leaflets as well.
Thank you.
Okay.
Thanks very much. Thanks, Carole. Shall I come back to you, or do you want to move on to another?
Thank you.
Or another clip, perhaps.
Thank you very much. So we're going to show you the second extract now. This is more information about bowel cancer and breast screening, and about some of the adjustments that people could ask for. Thank you, Amrah.
What they needed to do.
Yeah.
I had bowel cancer a while back. What did you notice was happening? Change in my body. A change? What was that change? In some ways, just going lower. Not normal. So it didn't look normal to what you normally see your tummy as?
We were talking about it at the doctor's, and then I decided to have a mammogram because I've never had a screening before, and I was a bit frightened, but I thought, oh, I'll go for it. But when I had the results, it came back all clear.
As a carer, you would probably book the appointment for your client, and the clinic might not always know your client's needs. You need to make sure to mention these so that the clinic can make appropriate adjustments to the appointment to suit your client's needs. Such adjustments can be making sure there is wheelchair access in the practice, providing easy read appointment letters, giving someone a preferred appointment slot if they find it difficult waiting in their GP surgery or hospital, later or earlier appointments. Priority patients, getting appointments and having access to on the day urgent or emergency appointments, even if their condition does not necessarily require on the day access. Longer appointments if someone needs more time with a doctor or nurse to make sure they understand the information they are given. Information in easy read before and after the appointment. Easy read on fast track referrals and cervical screenings, etc. being able to bring in their carer or support worker even during COVID times. It's also good practice to sit down with your client and to write down any symptoms they may have been experiencing so that you can bring that with you to the appointment. Bowel screening is a poo test, which is done at home and through the post. You will receive a test kit, a letter, a free post envelope, and instructions on how to complete the test.
Bowel cancer.
Thank you very much, and we'll hand over to Claire again now.
Thank you. Thanks very much. So, I mean, I think again, it's just asking. I'm keen to hear if anyone's got any comments about what people said there, or if anything kind of strikes a chord. For me, as a starter, I'll say that the person that talked about being worried about it, never having, clearly they talked to their GP, so clearly it was their GP who encouraged them to have the breast screening, which I think is a really important message. We've all heard about the value of GP endorsement, but it really is true. Even if we're not sure if it is true, it really is true. The statistics tell us that, and our patients tell us that. So, and this is another example of it. So wherever you can, general practice endorsement is really valuable. And as we saw in that clip, the patient who had agreed to have the screening for the first time in her life after having talked about it with her GP. So wherever there's an opportunity for practice nurses, practice HCAs, practice GPs, and actually practice receptionists to talk about taking up the general routine invites that people get for screening, it's really valuable. It will be worth talking to even your receptionists when people come in and they check in for appointments. When they do check in, it's less of them now than before, of course. In most cases, most practices tell me that their cough box flags up, and so you would see at that moment whether someone is short of one of their screening modalities. And so even at the front desk, that the encouragement or invitation to talk to the person they're going to have an appointment with about what's flagged up on the cough box is actually a really useful prompt for people, even if they're coming in for something else. Does anybody want to add to that at all?
In Barnet, the plan is that we are going to proactively call these patients and persuade and to persuade them exactly what you've just been saying, but we'll actually call them, and it means we can discuss things with them, like you're saying, make sure they get these leaflets sent, make sure they get access, maybe speaking to their carer or parent if that's appropriate as well. But it's just, it's to try and, have that role where, exactly like you said, where you're coaching them to saying, what questions have you got? What fears have you got? Let's talk about this. So that's the plan that we are going to be doing going forward.
Thank you. Will you also be sending out something to people who do the EAS clinical appointments? Those are the out of hours, virtual and face-to-face slots, Lorraine, around the consultation GP consult slots. I wonder whether flagging that with them as well might be helpful, because often the pool of doctors you draw on that provide that input's quite large, and won't all is not always from our local GP.
To be absolutely honest, I'm not sure on that. Is Rebecca Rogers on from, I can't see her, she's one of my colleagues, and she has done a little bit of prep work for the LD patients, but we, as I say, we've not yet started, so we're actually having more formalised training with an HCA on Wednesday, so I guess we'll find out about the appointments, etc. then. Sorry.
Thank you. No, not at all. Thanks. Anybody else want to make a comment? Fanta, if I could draw on you from obviously you're all things screening to the Alliance, you're lead all of our screening work. Across the whole geography, are there any particular messages that you've picked up about what we've discussed so far, either in clip 1 or clip 2?
I think the adjustments is a pretty big factor, particularly for breast and bowel screening, where it's not as easy to flag to the screening services that the person has a learning disability. I think for cervical screening, because you hold that record primary care is able to easily identify them. I know there's some work happening nationally to try and bridge that gap so that screening services will be notified, and then that would allow them to make the adjustments ahead of time. But yeah, for me, that is one of my biggest things, really. How can we bridge that gap in the meantime, so that clients aren't being missed out?
Yeah, okay, thank you. Okay, I haven't got anyone waving hands at me. Unless I've missed them, please just shout out. No, I don't think so. So perhaps we'll move on. Shall we move on to clip number 3, please?
Hey, thank you very much. So this is the continuation of bowel screening information and breast screening, and also talks about the results about breast screening. Amrah.
Thank you.
Thanks, Carole. Can everyone see the screen okay?
Yeah, it's got a phone number on it, yeah.
060.
I kept like an envelope, kept in the post. I did a poo in the toilet with a stick. Take poo from the poo on the stick and folded the envelope and turned it off. I didn't do it. It's a cake.
Well, we had to check in with somebody and say, oh, I've just come for a mammogram. And then we saw the lady in there, and then she said to us, well, I've got to get undressed, take my bra and blouse off. And then she took me into the room, and then she did the mammogram. Took one of my breasts in the machine first, and then they squeezed it a little bit. Then I did the other one in the machine. I was a bit frightened when I was going in there, but I was all right.
The process for breast cancer screening is different. Let's hear Dr. Nero explain that process.
This test can find changes in your breasts that are too small to see or feel and to detect breast cancer. On the day of your test, you'll be asked to attend your local breast screening unit, which is usually located in a hospital or mobile unit. You can take a carer or a friend along with you if you like. On your arrival, you'll be checked by the staff and they can help you to get ready for the test. A female health practitioner will then perform the X-rays called mammogram. The test involves scanning each breast one at a time. The machine will flatten your breast and hold it in place. You'll need to keep still just for a few seconds while the X-rays are being taken. Usually 2 images of each breast are taken. The test itself should not be painful, but may be a bit uncomfortable. After you've been X-rayed, the mammogram will be checked for any abnormalities, and the results of the mammogram will be sent to you and your GP within 2 weeks of your appointment.
This process is different for cervical cancer though. Let's hear Dr. Nero explain a cervical smear.
This is a test to check for any abnormalities in the neck of your womb. This happens at your GP surgery, usually by a female practitioner, such as a practice nurse. On the day of your appointment, usually the nurse or GP will go through the procedure with you and answer any questions you may have.
Thank you, Amrah. Thank you. We hand back to Claire now.
Thanks. Thank you. So I'm sure as clinicians weren't surprised by what Dr. Nero described, but I think what we notice and what we find when we talk to patients and families of patients and people with learning difficulties is that they sometimes say that it's difficult. They find it difficult to persuade their family member who's got LD difficulties to take up screening, and they wish that more was said in general practice about this. One of the things that people are worried about sometimes in general practice, Carole, is that people might say things once or twice and then they're worried that if they say it more, they're hounding people. And certainly certain patients do tell us extremely voraciously how they're fed up of being hounded to do X or Y. So it's about steering that middle course. With people with learning difficulties, would you judge that people need more repetition, or of course, in the same way, they may also feel hounded? How would you advise that GPs manage through that, to continue to give a message but not want to give it so often that it actually ruins a relationship between themselves and their patient?
Absolutely. Well, everybody's different and everybody has different needs and challenges. So for some people, you are going to be repeating it too often. But I think in the main, repetition is quite good. And I think it can't be underestimated, the importance of reinforcement from GPs and other healthcare professionals in encouraging people to have screening. And I think it's also a really good idea to involve the parents and carers as well, if possible, so it can be a fully informed decision that the person makes. But I think everyone is different. So some people will feel they're being hounded, but I think it's more important for most people. Repetition is quite good. It can sometimes take quite a long time, really, for them to really understand and interpret the importance of screening and how relevant it is to them personally.
Okay, thank you. And in terms of making appointments with breast screening now, we've moved for a system, haven't we, Fanta, from where appointments were given to now we're invited to make an appointment. How have we moderated or put in safeguards to ensure that people who might find it harder to make appointments, perhaps those with learning difficulties, get that done?
Yeah, so that's actually unclear. And I think it's one that we need to investigate a bit further because we are conscious that with the move to open invites, it has actually widened some of the inequalities that were already there. So I am interested to find that out from the breast screening service when we do have a conversation with them. How are they able to get over that? Are we seeing even less of a decline in the number of people getting in touch to book an appointment, or has it stayed relatively the same? So yeah, I'm yet to get some information around that, but in some ways I think it could potentially be helpful because at that point they could flag whatever adjustments are needed, but at the same time it could completely dissuade them from actually getting in touch.
Yes, absolutely. Deborah, you popped your hand up.
Well, this is where practices could help, isn't it? I mean, if you've got the patient, you can send them out to perhaps to your reception or get an administrator to make the appointment with the patient and things and do that for them. But yeah, obviously you need things in place, but you know, the practice could work as a mediator around that.
Yeah, yes, I mean that's a great offer. Some practices will feel that they haven't got the sort of headspace to do that, Deborah, and others will, but I think it's really helpful. The other thing, Carole, what do you think about striking while the iron's hot? What's your approach to if someone's in for something else and you think you can also fit in a smear or whatever it is, and that person at that point in time is, do you feel people with learning difficulties find it harder to be or easier? Would they perceive themselves to being rushed into a test or not? Or what's your view on that?
Well, I think you've actually hit the nail on the head. I think that it's a very good opportunity, isn't it, to get people to have some sort of screening if they're there in the surgery. If you have the time to spend with them, time to explain it properly and to give them time to think about it. And that's not always easy, is it, when you've got a set appointment?
It's often very difficult, but opportunistic screening is, I think, something that we should all try to make time for if we can. Deborah?
I think that is good, but I think in reality it's normally only the nurses who can do smears. I mean, because of the way the accreditation works now. So it would require a bit of logistics because often, I mean, I think nurse clinics are sort of rammed these days at the moment. They are under such pressure, and we've got so many staffing gaps. But obviously, opportunity is very good. But I think, well, I don't know. I think most of our GPs are no longer accredited to actually do smears. So.
I think it's varying across the board, but absolutely things change. That's right. Lorraine put a comment in around wheelchair access, and I know, Zarina, you've talked about that or encountered issues with that in the past as well. Do you want either of the two of you or both of you to talk about that a bit more?
I was responding to what Fanta said about the appointments, because you're right. If we spend some time with these patients who are reluctant to do something, we persuade them to do it, make an appointment, but we haven't checked exactly like you said, is there wheelchair access? Is there going to be, you know, that sort of thing? So that's something that's got to be really part of the process. I've made a note, so when we do our training, that we really have when we're making these appointments. Are we making them, or do we just refer them on to someone in the surgery who then, you know, that's we don't yet know how we're going to do that.
No, I think
to bear in mind.
Yes. Yes. Okay. Yeah. Serena, can you hear me? I don't know if Serena can hear me, but so the other thing is talking about what happens if patients need a hoist for a cervical smear. Carole, have you come across that?
No, I haven't personally, but it is something that does need to be considered very carefully. And then, of course, you get into the realm of capacity to consent, don't you?
Yes.
And that's another quite difficult area as well altogether.
Yeah. We haven't got time to cover all of that today, but clearly, if you meet people, if you have patients with that degree of physical disablement, it's you need to make sure that they're booked into an environment that can cope with that, and if not, speak to your PCN or our cancer lead. Serena is cancer lead for Barnet. Nitika, who's on the call, is a cancer lead for Enfield. Kate, who I think isn't with us today, our other NCL cancer lead can also field those sorts of questions, but it's worth bearing that in mind. And secondly, the other point that Carole raised around the ability for someone to make a decision around an examination, which, if you didn't understand what was happening to you, would be hugely worrying and disconcerting. So it's important to understand about capacity as well and record that when you're taking that test. In the future, I hope, of course, as we move towards when UScreen publishes, Fanta did an awful lot of work with UScreen, and we get to the point where we hope we'll be able to roll out the self-swab testing for cervical screening. Then again, that should be particularly helpful in this environment. Yeah, but we haven't quite got there yet. We've got various hoops to jump through with NHS England but we will get there. We're marching through resolutely. We'll get there in the end. Does anybody want to ask any questions around that sort of a topic? Or would you like, are there things that you feel you need in the surgery which you don't have, which you want to raise today that we can take away and consider? People are like quiet. Okay. Deborah, you popped your hand up again.
Yeah, sorry. Yeah.
No, it's great.
So going back to that with the cervical screening and consent, and whether people should or shouldn't have the screening. I find that a little bit of a minefield around some of the more profoundly learning disabled patients, and how much we should pursue and persuade around having that, because obviously in theory, if you're not sexually active, but obviously they are vulnerable people who might be, they're at risk as well, often because of their disability. So there's that whole cohort of people where it's quite tricky around whether you pursue whether they have cervical screening or not.
Absolutely. Okay. Before we leave this area, Carole, is there anything else that you want to talk about?
No, not really. Obviously, cervical cancer screening is the most problematic amongst people with learning disabilities, just by the very fact it's seen as being more invasive. Obviously, the new innovation you're talking about home swab kits will certainly help. But I think that it's about giving people time and explaining to them, not just sending them a letter, but for them to actually be able to have a discussion around the importance of cancer screening, and how that although it seems quite difficult, it's not difficult, and that it's a little bit uncomfortable but doesn't hurt, and giving people time can go a long way actually to helping them understand and persuading them to go ahead with the screening.
Yeah. Yes.
Yeah.
I was just typing in the chat, Deborah. I was saying reading the tea leaves, which I'll just soon hit return to. I think it'll be 2022, 23 before we have that rolled out completely across the country. Do you agree with that, Fanta?
Possibly. I'm less optimistic.
Yeah, maybe I'm a bit too optimistic. Absolutely, but it's certainly where we want to go. Yeah. Okay, so I think the one really important central message here is that it's all around communication, different types of communication, and how central primary care is to opening up that dialogue, and both with patients with LD, but also their families and their carers, if that's appropriate, to try to encourage people to keep up with their screening. And I think obviously the cervical screening, that's something that is done to you as a patient. So the competencies of doing it rest with the clinical teams. With bowel screening, and that's same with mammography, but with bowel screening, you need to do it yourself. So there are several things that are really important. It's really, really important to ensure that people understand how to do the new bowel screening. With carers, it's important who may have been aware of the previous type of bowel screening. They need to be reminded that the kits are new and you use them in a certain way. And also, one of the things that people often forget is that loo water from the toilet, will contaminate the sample. So for all carers or people helping patients process their bowel screening kit, it's really important that people understand it's helpful for them to do it with the person. Probably, I find that people, whether they have learning difficulties or not, find it very difficult to do that screening absolutely properly. It's very easy to do it badly and incorrectly, and it takes a bit more time to do it properly, and it's quite fiddly. So I think that in terms of ensuring you don't get the sample contaminated with water, and you use the sampling probe in the correct way, and it's again different from what you would imagine, so you need to talk through it quite carefully. And I'd urge GPs to have a fit test, which is the test that's exactly the same fit test that's sent out from the bowel screening program, and actually take the thing apart and show people the two parts, show people where the liquid is, and that the liquid shouldn't be spilled from that little container, and also show them that when they shut the container, it must make an audible click, and if it doesn't make an audible click, then it hasn't worked. So those sorts of things are really important. Thank you. Carole.
Absolutely. And actually the film that we have shows in detail how to do that bowel cancer screening test. Right. It actually shows it very well, I think. So we have one final extract to show you now, and this is actually the importance of cancer screening and encouraging attendance from the perspective of clients and healthcare practitioners. Thank you, Amrah.
Thanks, Carole.
Of your appointment, you'll get your results.
So say one of your friends said, "Oh, Tommy, I got a letter and I need to go and have a cancer screening test." What would you say about it?
Go and try it.
Yeah. Why should they try it?
Because they'd be better off.
I'm really happy that I wasn't going to go. I thought, oh no, I don't really want that. And then I thought, oh, I'll give it a go. So I did it.
Just be relaxed, calm down, and go for it.
Cancer screening is very important. Screening tests are designed to pick up cancer when you do not show any symptoms. Cancer testing saves thousands of lives each year. We know when cancers are found early, they're much easier to treat, and the treatment is much more likely to be successful. Remember, it is your choice to have the test or not. But there are more good points than bad points about screening on the NHS, so we would highly recommend that you have the test. Sometimes words such as cancer or screening can make you worry or may make you feel scared. But remember not to be afraid or embarrassed to ask any questions. Feel free to speak to your relative or carer, or your nurse, or even your GP, who will be able to answer any questions you have and give you any information that you need to allow you to make a decision.
I hope this video has explained to you the process of cancer screening and its importance. We can all work to prevent, detect, and treat cancer early by taking part in these screenings and being aware of cancer symptoms. If you would like further information, please visit www.nhs.uk/conditions/NHS screening/ or speak with your GP.
Thank you, Amrah. So I'm going to hand back to Claire now, who perhaps might want to open it up to a wider discussion.
Thanks. Thank you. Okay. Thanks very much, everybody. I don't know whether I really want to throw it open to the floor. I don't know whether people have any questions or want to share any experiences about anything at all around this subject, really, or what you think we need to do better, or what we could do differently. Fanta?
I can say yes to Deborah's question. Yes, I think some of the reasons are already on there anyway, but we can make sure that any further ones are put on. So just wanted to find out from practices if any of them review their prior notification list for cervical screening to see if they have any patients on there that have a learning disability, to contact them first before their invitation letter comes through.
Just have a look. Don't be shy, just shout out. I don't know how many I can't see how many practice nurses we have on the call today, but I think those lists tend to be reviewed. If they are reviewed, they tend to be reviewed by the nursing teams that manage the screening nowadays. So that's probably a question. I think what would be really helpful is to make sure that we have shared it within Barnet, but whether we can make sure we've shared this more widely across all of NCL, the video in terms of all our nurses, so that they're aware of it all. I think that would be helpful. And certainly putting together a list of suggestions which might help people, and that's the most practical one, I think, that you've described already, which is searching the list for people that might need some pre-contact to discuss things further. Lots of people seem very shy this afternoon. I think a lot of the GPs will have, quite a few of them will have seen perhaps those clips before. We have shown them before in a couple of webinars, actually, so they may have all seen portions of that film. I've certainly, with patients that I've spoken to, Carole, I've had really good feedback. People like the film, they find it easily understandable, and it's an easy watch. It's, you know, the kind of, although it's quite long, it's 20 minutes roughly, isn't it? 22 minutes. Yes. It's people feel that it's helpful. You put one link in the chat, I saw, but I'm wondering whether it would be helpful for people to receive by email the link of the video. Catherine, is that something that you could do so that they would they could send it on to their practice manager and it can be loaded into somewhere where you can access it later easily?
Yes, certainly. We can send that link on to all those that are attending today. Okay,
and yeah, I think that would be the best thing, actually, and perhaps letting your practice manager have a copy of that link as well. If you're anything like me, on the day you want it, you won't have the link in front of you, and so it's better to have it somewhere that we can access it easily. Okay. Any questions that people would like to ask? Or any experiences that you'd like to share?
Yes, Amina is asking.
Sorry, I have a question with the cervical smear.
Yeah.
I received a letter through the post to make an appointment. But I wanted to know, when is the best time to have a cervical smear?
Do you mean best time in the cycle to have a cervical smear?
Yes. Yeah.
Okay. So what we ask is for people to have it people will say mid-cycle is the ideal time, and then that doesn't mean one day. So it means you ideally would prefer not to be having menstruating at the time, and so people would normally say aim for mid-cycle and then take sort of a week before and after that. But any smear is better than no smear. So if you speak to gynecologists, they'll tell you that it's better to take the smear than not take it at all. So if someone is with you opportunistically, even if they're menstruating, you should try to take the smear, because the smear is measuring different things, and actually blood leaves the womb at different times during the cycle, even during the few days that someone's actually would regard themselves as actually bleeding. And so often when you take a smear, it's possible to remove a lot of excess blood before you then take the actual sample. So my own view is opportunistically whenever. So if you can't be sure that someone will return, it's better to do it whatever. You can maximise the readability by ensuring that it's closer to mid-cycle, but it's by no means an absolute requisite. Does anybody have anything they want to say about that?
I think the labs are quite vociferous around some of the things that they process and won't process.
Oh, so that's right. I didn't include that. You're absolutely right. Thanks, Deborah, for reminding me. Of course, one of the other things is how often you can do it in a 3-year cycle. So in the UK, we do our screening smears every 3 years. And if someone asks for a smear, a routine cervical smear at 1 to 2 years, then and if you take that sample, the problem is the lab won't analyse it. So one of the things that is important to do is also to check with your screening lists whether people are in the right part of their 3-year cycle to have the smear taken. And we had an issue a bit ago where we had some texting sent out from the national team, didn't we, Fanta, which kind of unfortunately the dates were not clear, and so people were called for screening who were before their 3-year time frame, and actually although they had been positively called by the system and they duly turned up, were given an appointment and had a smear, those smears weren't analysed because they weren't within the 3-year, and they were out of the 3-year cycle essentially. So it's actually very important to, before you actually take a smear, do make sure that that person is at the correct point of time in their personal screening cycle, which is usually a 3-year cycle, but might be different if they've got other pathologies, and that will say that on Open Exeter. So accessing Open Exeter before you smear is really helpful. That error regarding that nationally sent out text messaging has been resolved now, so it's not something that you should meet again, but it was a problem a few months ago for a very short amount of time.
So what you've just said, Claire, that sounds like really good, that we as care coordinators, that's information we could be making sure that the patients and or their carers know.
Yes.
You had your last smear, you're not, great, well done. Write it down.
You don't need it for 3 years.
Exactly.
Usually 3 years, right?
Getting them to write these things down so that we know, but they also know themselves, because, some LD patients are going to be really good about that sort of thing. We'll maybe know about dates and we'll be able to stick to it, but they need that information, and their parents, carers need the information.
It's really important, because it's a lot of us who are organised would say, well, let's get it done early, like people who write their Christmas cards early or something. But this is like writing a Christmas card early and the post office refusing to deal with them. So and then it's really difficult and annoying and upsetting for people when they go through the action of having a smear and then your sample is thrown away. So you have to be due your smear in the NHS to have it. And so it's always about understanding what your due date is. And for GPs, Lorraine, that will be on the Exeter system. They can also work out when someone is due also from when the last result was as well, to a degree. But if they're not sure, the ultimate record is Open Exeter. I think most nurses tell us that they always try to check Open Exeter before they actually do the smear, but sometimes people slip through the net. So, and we certainly found that, but that was partly perhaps because we were right in the middle of COVID when this other error unfortunately happened.
I mean, our searches will be run on people who are due or are overdue, so we shouldn't need to worry too much about that. But I was just making more of the point that I think is, as in empowering the patient or their carers, is telling them, you know, to expect it, so that perhaps once they've had it done, then it means that some work can be done at home with, remember you had it last time, it was fine, you know, you were worried, but we had it done, well done you, and it's coming up again. So that might be, you know, good for them to know that information as well.
Yes, no, absolutely. Absolutely. Yeah. Thank you. Are there any other questions or queries? Amina, have you going to say something? Yeah.
Yes, and in terms of the breast screening,
yeah,
I know it's a bit uncomfortable and worrying. Is there another way to do a test without actually going for the? No.
No, there isn't. Not for an NHS accredited breast screening is in a special breast screening environment. So I'm just going to mention, in case people have seen it on social media, so there are other ways of scanning breasts, and they do sometimes give useful information, but they don't replace breast screening. So the one that sometimes people find in social media is thermography. Thermography is an interesting investigation, and it has certain uses, but it's not the same as breast screening. And even though in some of the social media things I've seen, people are suggesting that over breast screening with a mammogram, it's not the same. So you know, it's just breast screening. But what I would say is that if you explain, when you're standing in front of the person who's doing the breast screening, and you explain, if it was tender last time and you explain that, and they can be extra sort of particularly careful not to cause discomfort. And it's worth saying to you, the person who's doing the test, actually it was a bit painful last time, can you try and make it as least painful as possible? And certainly there are ways of taking the screening test which will make it more acceptable for people. But the radiographers are really skilled in that if they know. So it's about sharing with the radiographer. Good. So I think we should, we've come really to the end of our time. Thanks very much for joining us. If you have questions later on, you could either put them in the chat and Catherine and I will pick them up later and respond back, or do what's required, depending on what it is you put in the chat. But otherwise, you know, we're happy to be contacted, aren't we, Carole and team? And you know, anything else that comes to mind, please let us know. Some people might ask about different languages. How many different languages are you going to use in terms of dubbing for that film? Have you thought about that, and how? And if so, how would they access a different language version? That would be helpful to know about. But otherwise, I think you might want to put that in the chat, Carole, and people could refer to it later, because we record these sessions. And of course, you can email your questions as well to us. Catherine and Fanta have organised this session in terms of the administration that comes from the Alliance. So please do email us if you like, in reply to your invitation to join this meeting, and we'll certainly come back to you. So just as a general reminder, remember, as a GP or as a practice nurse, anyone in any practice, a practice manager, we are regularly doing webinars with a focus on cancer. We run through all of the academic term times. And the way you get access is to contact Catherine to say that you'd like access, and then we will send into your Outlook diaries and emails, or MS Teams diary if you maintain an MS Teams diary, the actual invitation for the whole series. So what you need to do is contact us once then we'll send you, if you like, the invitation for a whole series, and then you can pick and choose without having to formally reply and register. And if you can't join quite at the beginning, that doesn't matter. We don't mind you joining halfway through if you've got other clinical responsibilities. We understand. Okay. Thank you very much, everybody, for taking the time to be with us today. And thanks, Carole and team, for coming and talking about it.
Thank you for having us. Bye-bye.
Thanks so much. Bye-bye.